Esteemed colleagues, I would like to give a floor to E.Solonitcin. He is endoscopist of our endoscopic unit, and he is also the associate professor of the Department of the Faculty of Surgery of the St. Petersburg St. Petersburg Medical University. Esteemed colleagues, we'd like to talk about such a small I'd like to talk about such a small organ as a major papilla. Well, I changed a little bit the topic of my talk. Added this word endoscopy in diagnostic in diagnosis of major papillary disorders. This organ is very small in size, but that's a root of confluence of biliary, pancreatic, and bile ducts. And that's a concentration of various morphologically different tissues. So it makes us to think about such comparison by Kazimaprutkov, and there are lots of talks in Russian proverbs. There are lots of methods which discuss the way how to visualize this area and to understand what's going on there. But still, there are lots of questions. There are lots of where we cannot provide good answers in all the cases. Not always we can provide good answers. In our clinic, we had a small research with not that many patients. So essentially, we took all patients who, after MRCP or RCP, had a diagnosis of the terminal Kaledach stricture. In all in CBD, terminal CBD stricture. We did EUS in all the patients. In all patients where we had indications, we did ERCP or surgery. So our purpose was to find out what's going on with the duodenal papilla and what's the reason of this diagnosis, terminal CBD stricture. We excluded patients, we immediately excluded patients with the signs of the large lesion at the major papilla. We had 22 men, 32 women, and these are our results. Majority of patients, they didn't show considerable changes, and we consider this change as an inflammation in the large papillary volume. You could see what we saw. In some cases, we saw adenocarcinoma. So the patients who had terminal CBD stricture. In one case, it was carcinoid, it was neuroendocrine tumor. And in one case, whom we want to send to surgical treatment, we found a stone within the ampullary part of the major papilla. So it looks like, coming back to this definition, it looks to be clear. We know where papilla is located. We have diagnostic methods. You can take endoscope, and so we can come, see, and win. Yeah, veni vidi vici. But when we talk about the conventional endoscopy methods, the most widely used is gastroduodenoscopy. In most of the cases, patients come for that study to diagnose major papillary vessel. And we often have this diagnosis that you should do gastroduodenoscopy with diagnosis of major papilla. But there are some complexities related to the structure. And even if the anatomy is normal, we not always can see the papilla and to see it in detail. The other thing, the next method is the endoscopy, and we can clearly see, and you can see major papilla quite nicely, but not all hospitals have this equipment, and to do it you have to be qualified in endoscopy. So now let's look at those disorders which we can find through endoscopy. Talking about the scar or inflammatory alterations, endoscopy would not be of much help. Usually the papilla is not markedly changed, but there are signs which could help us. This video, it might be too long, and it shows quite nicely what we can see here. Endoscopic image is a device, and we can see that the papilla is quite large. From the isthmus, you see some tissues. We have Perinea, so we could think that it could be a mass in major papilla or something increasing in size. We're doing endoscopic ultrasonography, and what we see is at some point of time we see such a hyperhygienic structure, which you might think of as some mass in major papilla. It's operator dependent method and the sonography. And at some point of time, this hypergenic structure, we could see it better, and it looks to be that it's a thickened walls of the papilla. So we start to think if there is, it might be the, it could be the scar stricture, and we follow it up, and you see in the transverse section of the major papilla, you could see peristalsis of and you'll see that how, along with the movement of the movements of the duct, you see here the ampullary part of the papilla. You could see it opens up and close up, and you clearly see that it's not a movement of the pancreas, but it is an intra-ampullary movement. So functionally, those symptoms are not related to some scar tissue. Not always we can see a papilla in such a way. There could be different anatomy, there could be different structures, but diagnosis of a scar stricture could be here excluded. At the moment, there is a classification of the odd sphincter dysfunction, which includes biliary and pancreatic type. Classification is quite clear. It has 3 parameters. It includes pain, liver functional tests changed, and expanded liver duct, and slow contrast removal, more than 45 minutes. If we see all those symptoms, it's a Frost type or sphincter dysfunction. There are types 2 and 3, and the same of pancreatic type. But what I would like to draw your attention to, this classification today could be used in practical settings. In other words, if we have all the factors, and if we diagnose type 1 of this odd sphincter dysfunction, then in this case, for manometry, we can see that almost all patients, they have pathology of papilla. And to majority of patients, we can do papillosphincterotomy, and we can take about the second type dysfunction, which should be more specific to the patients. the third type dysfunction, we can help not only to the halfway patients. With a normal sphincter function, we can help only to less than 10% of patients. The ERCP pattern, it's post-ERCP, incorrectness and other complications. So it's clear that if we see all the symptoms, we do not need any additional methods like sphincter manometry. We will just do papillotomy, and it will be helpful for the patient. And if we have only the symptom of typical biliary pains, then in majority of cases we cannot help them, we even can harm them. And there are often we have the discussions with gastroenterologists. I would like to draw your attention that this classification in a practical sense is very useful. The situation which we discussed, the stone in the papilla ampulla, this only endoscopy made possible to diagnose it. And the third part, there is a, so to say, you see here the classification of major papilla lesions. In most of the cases we see adenomas or adenocarcinomas. I should say that the clinical signs in case of large major papilla pathology, clinical signs are the same. In case of similar to other disorders, 90% of cases the only symptom is jaundice. In 70% of patients with jaundice we see T2 or higher stages. Lab tests are the same. I would like to talk a bit about oncomarkers. If we think about yesterday patients, when we do it ERCP, the main lab test which made us to search for the cause of the disease is high CA19-9 levels, but this oncomarkers is considerably elevated in cholestatic patients. So if it is a cholestasis marker, would be useless. What is the capacity of imaging methods? We can detect biliary pancreatic hypertension or identify large lesions, large masses. We're not talking about the stage 3, but we're not talking about T3 stage. And it's related to the resolution rate of ultrasonography, which is quite low. And the thing is that anatomical location of the lots of ways, there are lots of anatomical ways the major papilla could be, so to say, lots of ways of structure of major papilla. They all are classified by our Japanese colleagues on the following types. And in case of such tumors, we usually have no problems with diagnosis. Then if we talk about such pathology or that lesion, here we have to do differential diagnosis of such methods. When we talk about the EUS challenges and opportunities, of course, it is used to visualize and to see the tumors. We'd like to see small tumors at the early stages. Of course, we assess how far the tumors are spread. We look at the invasion, the depth of invasion, and we look if the lymph nodes are involved. We discussed these issues yesterday, but we know that the 14M stage in CT, MRI, and PET imaging is highly sensitive to identifying distal metastasis. In assessing lymph nodes involvement, we know that MRI is better than CT and EUS, and for T staging, endoscopic ultrasonography is the most useful because it's and it's very helpful for small masses. When staging, we have clear borders. It's a muscular wall of duodenum, and we can look at it, and it's easy to find when diagnosed. Why do we need it? It has been proven because T1 masses could be removed through papillotomy. This method, of course, it's better to remove adenomas without malignization. But if we clearly know that the structure is within mucosa, we can remove it through endoscopy. Alternatively, and it's a pancreatic duodenal resection, which implies different consequences for our patients. Several examples. It's a major papillary adenoma. Though this mass is quite large, we can clearly see that the muscular layer is still there, and ampullectomy was done successfully. Another example. Though on endoscopy it doesn't look large, it's hard to see those structures sufficiently. The ultra-sonography shows that the mass is outside the muscular layer. It invades pancreas parenchyma, and it blocks both bile and pancreatic ducts. The borderline T2, T3 mass, we can see that at one stage there's an invasion outside the muscular layer, plus the tumor spreads along the mucosa of the ducts. This large tumor, similar large tumor, it's still limited with submucosal layer. And EUS diagnosis is, of course, operator dependent. That's a method requiring special knowledge and skills and quite considerable experience. That's why during endoscopic during EUS there are some challenges or problems. Well, first of all, it's presence of parapapillary diverticula. Such diverticuli, they could be skipped at conventional gastroscopy because we have the optical system is located. We can just not see them because it's located at the end of the device. Those diverticles could imitate stone or cysts. Usually those diverticuli, they contain air or some other material. So peristalsis, the studies goes on in peristaltica. It could be quite considerable, and sometimes it could present diagnostic issues because the image is not stable. We cannot visualize the object, but peristaltic movements, they show us they make possible to diagnose rigidity areas or akinetic areas. An example we discussed, this is a big problem to diagnose so-called creeping masses, especially intraductal. It's really hard to visualize them. Another important issue I would like to draw attention of the clinicians is that any interventions prior to final diagnosing, prior to having so they will present problem for diagnosis. For instance, in particular, stent placement and pancreatic could be they could be complicated if we did some treatment prior to diagnostic routine is completed. Then the biopsy. There is data that is recommended to take at least 6 biopsies. Why? Because adenocarcinoma focus is found in about half of the cases of the papillar adenomas. Also, there are some specific features in biopsy in patients. So the clinician should know that biopsy has its own specifics. First of all, gastroscope biopsy performance is quite low. Then biopsy, if for intraampular locations, biopsy without sphincterotomy is low effective. And another important issue I would like to draw attention to, that negative biopsy does not exclude presence of cancer, for instance. There could be issues with differential diagnosis if the disease is located at the duodenal area, especially in case of the duodenal invasion. A recent case, for instance, was a patient with rather large adenoma, or large papillary adenoma, and he has lots of stones in CBD. So it was a combination of several diagnoses could have a place. So the arrows you maybe can't see now, but the data we use in the clinic, pathology of the major papilla, it's an important diagnostic step. In some cases, we could see not only major but also small duodenal papilla. That's now we're trying to study those even smaller area. I wanted to show you the sample. I managed to launch the video. Just another 5 minutes, even 3 maybe. So that's another large formation of major papilla. We detected it in a patient of 43 years of age. It covers almost the duodenal part. It goes to the lower horizontal part and to the descending part. You can clearly see that all structures of the duodenal wall are there in place. We see this layer-like structure of the wall, and muscular layer is present in all parts. We see ductal structures. We see that both ductal structures of pancreas and bile systems are not involved. So despite of the size of this lesion, we still can try to do endoscopic ampullary in this patient. So the disease is quite large. It is it's kind of a don't extend along with the duodenum, which usually try to remove this lesion and block, because it is quite large, because of its location, and there are angles and folds in duodenum, so we couldn't do it to remove in mass. So we removed it through resection, and we removed it in several pieces. Can we fast win this video? We see like we remove this lesion piece by piece. We remove small fragments, and I should say that the good high-quality optical system is a great help, because small fragments could be located at the bed along the edge of this post-op wound, and only due to the good optics, good visualization, we can remove. You see the almost entire lesion is removed. So the problem of ampullary is that after removal of this structure, there could be quite intense processes in the ampullary area of major and minor papilla, and so treatment should be ended up with stenting. We place a stent in the pancreatic duct. We did pancreatic stenting, and as a third stage, after some preliminary cutting, because there was a stricture, we couldn't get through with a standard endoscopic catheter. We can't get through the isthmus. You can see that the stent is placed in the CBD. Then manipulation is finished up with the procedures, which decrease risk because it's a biliary stent. So it decreases risk of post-op complications. One of those risks most often is bleeding. So the procedure ends up with argon plasma coagulation and clipping of the most important bleeding sources. Why I showed this fragment in so many details. So, and I would like to say that endoscopy is not stagnating. We get new tools, new instruments. We're working with anesthesists, and they have their own novelties and new technologies. And so it helps you to do the manipulations, which before require aggressive surgery. And thank you for your attention. Esteemed colleagues, are there any questions to the speaker? Please pass the mic. Could you tell me, please, do you use submucosal injection in case of papillotomy? And if not, then why? In some cases, of course, we use submucosal injection. We use it in most of the cases if the lesion is rather, so to say, widely spread. We try not to inject anything into the isthmus area of major papilla because it might result in additional edema, in additional reaction, response. That's more of a theoretical idea. I haven't seen any studies about it, but so we're trying to be more careful with injection versus the resection of structures in the colon. What's the issue with the edema? There could be issues with placing the cannula, with placing if there is an edema. Okay, more questions, please. Yes, please. Yes, Dr. Deshano. Yes, please.
Example of your work. Tell me, sometimes I've got big problems bringing in a pancreatic stent after resection of an adenoma. Do you have those difficulties, and what do you do when pancreatic stent placement is not possible?
Alex, I think we just lucky because we didn't have these problems, but I know that it could be. I think it just because we have only few the same cases, maybe 15 ampullectomies.
Mm-hmm. So you always place the stent afterwards?
Yes, yeah. But I know sometimes we place pancreatic stent after standard ERCP, for example, for post-ERCP pancreatitis or for other reasons, and of course cannulation of pancreatic duct is more difficult than cannulation of CBD. So we have some tricks for cannulation. For example, we cannulate the CBD at the first, place a stent there, or just a guide wire there, and then we try to find pancreatic duct. Or we can cut a little the surface of the pancreatic orifice and try to put there guide wire. I think that we sometimes we have problems with this, and it's maybe in 90. We can do it in approximately 97%, but of course 100% we can do anything. We just have to stop because the procedure is too long in this case.
It could be a good topic for discussion during round table.
Yes, I think so.
I think so. Thank you very much. Уважаемые коллеги, есть ли еще вопросы?
Esteemed colleagues, are there any more questions? And how you determine the borders of this tumor-like lesion prior to resection? The borders were defined mostly during EUS because the lower border of this lesion, it was not fixed to the duodenum, and you could see it at ultrasound. Because if you pump the liquid, you could clearly see the shape of this lesion, and with the resection we can clearly see the edge, and we can see if any tumor-like structures are there, or we remove them all. If I understood your question right. No. No staining. No, staining is not required here, because we can see here through optical system. The same situation is with colon. While in stomach, we have to stain the margins, the borders, and we follow this staining border. Resection there in duodenum, it could be done without staining because we could clearly see all the margins. Take the microphone, please. And could you tell me, please, when you resect such a large duodenal lesion, which is a maximum surgical volume you discuss with the patient? Pancreatic duodenal resection, of course, because in case of severe complications, such surgery might be necessary. Outside the scope of those presentation, with this issue is outside the scope of the presentation, but of course we explain everything to the patient. We're hiding nothing from the patients. We describe all potential complications and in potential ways the situation might develop.